Now it's the time for Professor Geerps from Amsterdam, the Netherlands, to present us the ICU Compendium of Commonly Clinical Used Drugs. Please, Professor Geerps, the floor is yours.
Thank you very much, Dr. Katia Donadello. Thank you very much for this nice introduction. The title I was given is the ICU Compendium of Commonly Clinical Used Drugs. What I'm going to do is discuss with you some basics of what you should know when you prescribe drugs in the intensive care. First of all, my declaration of potential conflicts of interest. I have no potential conflicts of interest whatsoever related to this presentation. Now, why is medical therapy in the intensive care different? And in order to discuss this, we need to address some basic principles of pharmacology, which is, of course, pharmacokinetics, that is how the body handles the drug, and that is also pharmacodynamics, how the drug affects the body. And I hope to keep your attention for this presentation, and in order to accomplish that, I have made some questions first. So we have a septic patient who is fluid resuscitated and requires antibiotics. The creatinine level is too high, 253 micromole per liter, and ciproxin is indicated. So what dose should you prescribe? And as you all know, so from these facts is that the creatinine is much too high, meaning that the renal function is deteriorated. And you read in all the textbooks that in case of renal function loss, you have to reduce the dose of ciproxin. So which dose do you want to give? Do you want to give 400 milligrams 3 times a day, or 2 times a day, or once a day? Or do you think that none of the above is correct? And what I hope is that after this presentation, you will agree with me that D is the correct answer. None of the above is correct. Another example is a patient was started on amiodarone 2 days ago and redevelops atrial fibrillation. The patient was on a maintenance dose of 600 milligrams per day by continuous infusion after a loading dose, followed by 1200 milligrams per day maintenance dose during the first 24 hours. And the supervisor orders put it back on 1200 milligrams per day. So what is your comment on that? And the correct command is that this is not a rational therapy. Increasing the dose, the infusion rate without loading dose is not a rational therapy in this case, and I will explain that. A very small recall: what happens to the half-life time when the volume of distribution increases? Will the half-life time increase? Will it remain the same? Or will it decrease? So please choose your answer and see whether you're correct if you look at the rest of this presentation. And one of my favorite questions is, what is the half-life time of alcohol? Because it's a very simple test whether you are a master in the basics of pharmacology. And I could ask the same question for aspirin or omeprazole or phenytoin. And here you see already a figure which is from a very old publication on the pharmacokinetics of aspirin. Another question: what is the bioavailability of nimodipine in the non-ICU patient? Is it 3%, 88%, or 30%? Or is it anything between 3 and 30%? And the correct answer is D. Now, if you take a drug, it needs to be absorbed, it needs to be distributed, it needs to be metabolized, and it will finally be eliminated. And that comes with the acronym ATME. And I really want you to remember this acronym. The absorption, when a drug is taken, can of course be via the gastrointestinal tract. If you take it by mouth, whether it is absorbed, or if you use a suppositoire, or if you give it intravenously directly in the circulation, or if you use ointments. And the goal is, of course, that this drug is then distributed to the tissue and goes to the cells or where it has to work. It is then metabolized and finally eliminated, because the ultimate goal is that your body will be a drug-free zone. So again, the acronym ADME: absorption, distribution, metabolism, and excretion to be remembered. The absorption can be in different ways. It can be a passive diffusion, a facilitated diffusion, active transport, or endocytosis. So here you see how it is with passive diffusion. There is a membrane, there is on one side a high concentration and a low concentration, and then there is an equilibrium, making it that the concentration will be on both sides approximately the same. In case of passive diffusion, it is that a water-soluble drug is through the pores in the membrane, and a lipid-soluble drug will go through the membrane itself. A facilitated diffusion is that there is some help of carrier proteins that will help to make that the compound will go to the other side of the membrane, so there will be an equilibrium again of the concentration on both sides of the membrane. Active transport requires energy, so ATP is involved and necessary, and the compound is brought over the membrane using an active transporter. And finally, endocytosis is where a vesicle is made, where the drug is in, and then it is released in the cytoplasm. The key message of this is that the absorption can be quite complicated. So ask yourself every time when you give a drug in the ICU patient, what happens to the absorption? And this is also true for the absorption if you give it via the gastric tube or orally. How is the gastric emptying? What is the bowel transit? How is the absorption? Is there bowel edema or is there bowel hyperperfusion? Can you predict absorption? And how important is that you get exactly the right dose of this compound in the blood? A very important characteristic for that is the bioavailability, the extent of the absorption of the intact drug. And of course, when you give it intravenously, the bioavailability is 100%, but that is not the case if you give it orally. And what you can do is then calculate the area under the curve. This is the curve for intravenous, and the area under the curve represents the amount of drug that has been given and is in the bloodstream. And this is the curve in case of the oral administration. And therefore the bioavailability is the area under the curve per os divided by the area under the curve IV. And bioavailability is very important because you want a drug to be delivered and you want a drug to be present at the right concentration. And therefore it is even more important in intensive care patients is that the bioavailability is quite unpredictable in your patients. I give you some data about bioavailability of different drugs. So oral ciprofloxacin has a bioavailability between 50 and 95%. And it can also be different in patients with cystic fibrosis and also different in younger patients with cystic fibrosis compared to older patients with cystic fibrosis. Nimodipine orally has a bioavailability that varies between 3 and 30%. So this is a tremendous difference, of course. And it is even more unpredictable in the ICU patients, where you can have problems with gastric emptying and the transits. Now, loperamide orally has a bioavailability of approximately 40%, but there is a very important first pass effect. And as you all know, it's a morphinomimetic. So, but there are no effects in terms of morphomimetic effects of this, because after the first pass, there is less than 1% in the circulation. Now, the distribution of a drug is determined by several factors. Lipophilicity is one of those factors. You have a high distribution when it is a lipophilic compound and a little bit lower distribution when it's hydrophilic. It's also dependent on the blood flow, it's dependent on the capillary permeability, and it is also dependent on the plasma and tissue binding. because albumin slows the distribution process. That brings me to the volume of distribution. The volume distribution is very simple. It's the amount that is given divided by the concentration. And that is of course because the concentration is the amount that is given per volume. Now, if we look at small lipophilic versus large protein-bound compounds, you will see that small lipophilic have a very high volume of distribution, and large protein-bound compounds have a relatively low volume of distribution. And if you know this volume of distribution, it will help you to calculate the loading dose, how much of the compound should be in this basin. Some examples of the volume of distribution for a 70 kilogram man. So digoxin has 420 liters of volume of distribution. It is very lipophilic. Ciproxin 140 to 200, warfarin 8 liters because it's a high degree of protein binding that is the case in this compound. Alcohol 30 liters because it is distributed over the total body water, and chloroquine 15,000 liters because it's a very lipophilic, and the same holds true for amiodarone. So some typical values for the volume of distribution: when it is 5 liters, it is a very high molecular weight, protein binding, and a good example for this is heparin with the distribution of 4 liters. If it is hydrophilic and a low molecular weight, and I give you the example of rocuronium, you can expect a volume of distribution of 14 liters. If it is diffused intercellular to the intercellular fluid, then the volume of distribution is the total body water, which is the case in ethanol, as I mentioned before, and alfentanil. And if there is a strong binding to tissues, then the volume of distribution is of course higher than the total body water, up to 280 liters, 560 liters for propofol, and 420 for digoxin. And this gives you a list of different compounds showing an increasing amount of the volume of distribution. Now, things would be simple, of course, if we consider the body as one compartment, and you give a drug, and then you can very easily calculate the concentration in this compartment. However, it is not as simple as that, because there are different compartments in the body, and there is also a different balance of exchange of the compound between these different compartments, so that makes it not easy to know in which compartment which concentration is present. Now, what are the consequences for the intensivist? There is a big variance in distribution. Elimination of the drug is very important, and I asked you what is the half-life time of alcohol. And when you think of this, please think back about the Brexit episode, where we had this honorable gentleman saying all the time, order, order. And that is in fact what is very important for the elimination of alcohol, because alcohol follows a zero-order kinetics. And what is a zero-order kinetics? It means that the rate of elimination is constant. The amount of drug that is excreted is always the same. So if this is a period of 1 hour, after 1 hour, 200 milligrams is eliminated, and the next hour again 200 milligrams. So you know that after 5 hours, everything has disappeared. And if this is the concentration and this is the time axis, you can see that there is a reduction that follows this straight line. But if we then look at the half-life time, you see here again the concentration, and you see here the time. If we look at when the concentration is reduced from 0.2 to 0.1, you see that this is approximately 12 hours. So this was the half-life time. However, when we go from 0.1 to 0.05, it seems far less. It's going from 12 to 16, 18, I have to say. So it's about 6 hours. So there is a difference, and this, of course, cannot be possible. And this indicates that there is a zero order. And some examples of compounds that are eliminated by zero-order processes: alcohol, aspirin, cisplatin, phenytoin, and omeprazole. We are more used to what we call the first-order kinetics, and that means that the rate of elimination of a drug depends on the concentration of the drug. So if there is every hour 16% that is eliminated, as it is here, it is after 1 hour 840, then 706, and then 593. And this comes very familiar to you, I suppose, where you see this concentration. And here it is very easy to see that if the concentration goes from 8 to 4, which is exactly the half of it, it is 2 hours. And it's the same amount of time that is needed to go from 4 to 2. So this is the first order kinetics. And you will all remember from high school that if you use a logarithmic scale, that it becomes a straight line. Another important thing is the steady state. And steady state means that the concentration of the drug remains the same. And that is also very simple. It means that what is given is the same and that what goes out. Now, a question for you might be, is the required dose in a steady state dependent on the volume of distribution? Or is it dependent on the clearance? And the correct answer is that it is only dependent on the clearance. So that means that the given dose equals the clearance times the concentration in the steady state, or the concentration in the steady state is the given dose divided by the clearance. I come back to that later. You should ask yourself, if you know this about the steady state, what is the consequence for your patients? What is the consequence when you have a zero kinetic process or a first order process? What is the consequence of the variation you see in the volume of distribution, and what is the consequence of changes in clearance? If you have a zero order process, such as the cases in alcohol, it means that if you give a little bit more of alcohol than is eliminated every hour, the level will rise endlessly, and that will lead to, of course, the death of the patient. Clearance is also a very important feature to know about a patient. The clearance is the volume per time unit that is completely cleared of a substance. So all the amount that is in this volume is then removed. And that you can very easily calculate. The concentration times the volume is the amount that is removed. So the amount that is removed is the clearance in a specific, the concentration and the amount of the compound in a specific volume. That is, in fact, the clearance. We come to some formulas. In the first order process, I explained to you that the elimination is depending on the concentration. So the higher the concentration, the more is removed. So it means the change in the concentration divided by the time per time unit depends on the concentration times a K, which is the elimination constant. And if you put an integral on it, and then you go to a logarithmic, you will see that K times T is the logarithmic of the concentration at time 0 minus the logarithmic concentration at time T. And what I do is I get my old books of mathematics back again and have a read to see this. And I will explain this to you in a minute again. So if you then say that if you want to know half-life time, it means that the concentration at time 0 is 2 times as high as the concentration at time T. So K times T equals logarithmics, the concentration at time 0 minus the logarithm at concentration at time T. And then it's very simple, because the logarithmic of 2 is 0.693 and the logarithmic of 1 is, of course, 0. And this is a very important formula for you to remember. T half equals 0.693, so the natural logarithm of 2 divided by k. And remember this, because if you now combine this with the clearance, you come to this important formula. Half-life time is 0.693 times the volume divided by the clearance. And I have written this in my own handwriting, and I advise you just to stop this presentation here and go through this very slowly. So what happens to the half-life time when the volume of distribution increases? And I ask you, will the half-life time increase? Will it remain the same, or will it decrease? Now let's have a look at this, where a doctor adds some drugs in a basin which contains 990 milliliters. He adds 10 mils, and we will have a specific concentration. Now, what is the clearance? The clearance is, let's say, 10 mils per minute. That means that every 10 minutes you pour out, every minute you pour out 10 mils of this fluid, and you replace it by 10 mils of completely clean, clear fluid as given here. And if we use this formula, you can calculate that the half-life time is 69 minutes. And this is a volume of distribution of 1 liter. Now watch very carefully. We will increase the volume of distribution twice as high. We will have the same clearance. And what happens, according to this formula, as you can see, we will now have a half-life time which is 2 times as high. And that is very important to remember, because in our intensive care patients, there is a huge change in volume of distribution. Now, for the elimination, the kidney is the most important organ. It is, however, difficult for the kidney to excrete lipophilic drugs, and there is where the liver will help with a phase 1 and a phase 2. The phase 1, it says oxidation, hydrolysis, and reduction, which is catalyzed by a cytochrome P450, very important to know and to remember, and a phase 2 where there is an additional conjugation reaction. And why is it important to be aware of this? Because there are a lot of inducers and inhibitors of the cytochrome P450, as you can see here. And especially when we use polypharmacy in our patients, it is good to know how one compound may influence the pharmacological properties of another compound. The hepatic clearance can also vary very much between drugs, but also when there is a change in hepatic circulation or hepatic function. So the extraction ratio tells you something about how effective the clearance by the liver is. If there is a low hepatic clearance, such as in these drugs, clindamycin, diazepam, compared to where there is a high extraction ratio for these compounds. And they also depend then more on the liver function, as you can imagine. Now, is this useful to know? It is very useful to know, because the pharmacokinetic in ICU patients can change a lot. If there is a hyperdynamic circulation, there can be an increase in creatinine clearance. If there's a positive fluid balance, you will have an increased volume of distribution. If there is a reduced protein concentration, it is accompanied with an increased volume of distribution and clearance. Renal function deterioration, on the other side, will give a decreased renal clearance, liver dysfunction, induction of the cytochrome P450, which will lead to an increased clearance, renal replacement therapy, and ECMO all have their influence on the excretion of the drugs that we administer. A higher volume of distribution, which is very often the case in our ICU patients related to capillary leakage, edema, ascites, pleural effusion, altered or less protein binding, there is the very important risk of underdosing. You think that the patient has this volume of distribution, whereas in fact, after you have resuscitated the patient, this is the volume of distribution. And these are the data where the advices are based on that you read in the textbook. and this is reality. So a higher volume of distribution than anticipated has consequences for pharmacokinetic properties. And you know now what happens to the half-life time if the volume of distribution increases. And you also know now what it means if you give an initial loading dose. The hyperdynamic state may increase the clearance, such as is the case in increased cardiac output, whereas on the other side, end organ dysfunction may decrease clearance. And this has very important consequences, especially for drugs like antibiotics and your dosing strategy, because you need a specific concentration, a minimum concentration of an antibiotic, the MIC, that is required. And as you know that there are different properties that are relevant for antibiotics, some depend on the Cmax divided by the MIC, some are more time dependent, and other antibiotics are time and concentration dependent, as you can see in this figure. So that is why, for instance, penicillins is very wise to give this as a continuous infusion, because it is time dependent and the time that the concentration is above the MIC. And you can find in papers or in textbook relevant PK/PD targets for different antibiotics. And this can of course be debated, but at least it gives you a better guideline than just following the regular dose. If you look at the compound, it's good to know whether it is lipophilic or hydrophilic. And why is that? Because hydrophilic means that there is a poor bioavailability, it is in a relative small volume of distribution. That means that if there is sepsis and the patient needs fluid resuscitation, there can be a big change in the volume of distribution. It can distribute in the extracellular space, and renal clearance is the most important factor. Whereas for lipophilic, it has excellent bioavailability, a large volume of distribution, and therefore in sepsis there is a smaller change in the volume of distribution. I give you some examples of antibiotics that are either lipophilic or hydrophilic. So you know that you have more to adapt the dose of a beta-lactam in a patient who is septic and has a change on the volume of distribution than is the case for macrolides. So some final words on the problem. Adequate dosing is a key element. Intravenous dosing in your ICU patients is in general preferably, because it is the only way that you have a really good predictable bioavailability. The variation and the changes in properties in one patient and also between different patients is huge. Most advices that you read in the textbooks or the compendiums are based on studies in healthy volunteers or in patients that are not intensive care patients. So with this information, I would advise you to make your educated guess, because a lot of data are missing. But you can do better if you are aware of these pharmacological important features. Check for interactions when you give a lot of drugs. Please check for interactions and be aware that one drug can influence the metabolism of the other drug. Use all available information as much as possible, so you can make an educated guess about the changes in volume and distribution, if you know the fluid balance, if you know how edematous the patient is, if there is a lot of ascites, etc. And finally, I hope in these difficult times that you will really take care of your own health and of your co-workers. And I want to thank you for paying attention to this presentation.
Thank you, Professor Gerbs, for this great presentation. I might have some questions. The first one probably is a little bit partisan on your behalf, but what is the value and the necessity of having a clinical pharmacologist within the ICU staff. I mean, daily present and daily evaluating both the patient's characteristics and the drugs that are applied.
Well, there are a lot of studies on these kind of features. Then when they say you have a pharmacologist or a pharmacist in the team who specifically pays attention to the medication, then outcome is better in whatever terms. There are studies that show that when you have someone who pays attention whether a patient can be extubated, that you do better. You have studies that show that if there is someone who makes a round every day and asks critical questions, that you do better. So what you need is that you as a doctor in your team, you pay attention to all these kinds of things. And whether you do this with a pharmacist or a pharmacologist or an intensivist or an internist who pays attention to this specifically, I'm sure it will help. So personally, I'm not always convinced by these studies where they say, well, if you have a pharmacist in your team, it will go better. Of course, it will go better if there is someone who specifically pays attention to this. But I think that can also be done by the doctors. And if they lack knowledge, they should work on it and ask a pharmacist. In our department, we have a pharmacist who is present during the discussion that we have over the patients at least 2 times a week. Mm-hmm. And it helps us to improve our knowledge on this subject, and it helps us to remain critical. So I think that is the most important thing to do. And how you organize this in your specific units, I think it is of less importance.
Okay. And I know that in many realities, the possibility of having a TDM measured is not a reality. It is not something daily present or daily available. So as far as what you have just presented and as far as how much PK/PD influence dynamics influence our ICU patients, would you suggest or would you recommend to introduce daily or at least something similar to daily TDM measurement for all ICU patients?
Well, that's a very important question. What I did not address very much is toxicity of drugs. So the more toxicity is important, the more you should address to know levels of the compounds that you are giving. We in our unit, we have a big program running about that we use all the knowledge that is available with data science and for specific patients, that we use all the data that are available from a patient, from the fluid balance, the renal function at that moment, the liver function as much as we can know. And then there is a real-time advice from the computer, from the program, based on all the knowledge that we have from the literature and from our patients. And there's a real-time advice given about the dose. And we are working on very hard. The study has come to an end, and we are now looking at all the data and hope to publish this very soon. We have published already some about this. But what we do, in fact, is we try to use all the knowledge that is available in a specific patient. And I'm sure that we can all do better than we do if we use our knowledge that we know about a drug and the facts that we know about the patient, and then decide about the dose of a specific drug that we can do better than when you just prescribe a standard dose. The regular determination of levels will absolutely help. And for some drugs, it is really absolutely necessary to look at levels. If you look at toxic compounds such as the aminoglycosides, it is really necessary that you are aware of which dose you should give in this specific patient. So it plays a role. The problem with TDM is also that it takes some time before you get the results. So you do not have the real-time advices right at the moment that you need it. So I think this is complementary with what I told about these basics and can help the clinician to find the best possible dose for his specific patients.
And how do you manage this whole evaluation of patients that are on the CRRT or on ECMO? I mean, what you have just described about your whole clinical examination of the patients, the fluid balance, the clinical parameters, and so on, are you seeing during your personal experience that this evaluation is also applicable to those patients that are on CRRT or on ECMO?
That is a very difficult question, but a very important question, of course. We should acknowledge that there is a lot of things that we do not know about these specific patients. What I want to make clear is it is not one size fits all. So you have to go for a very individualized treatment of your patient, because one patient on the ECMO is not another patient on the ECMO. They are not the same. And measuring drug levels can help you very much if that is possible. And again, there is, of some compounds, there is some literature on patients who are on chronic renal replacement therapy to know how the metabolism of the drug is and how well it is excreted, that are helpful. But you are absolutely right, is that there is a lot of information missing. So what we do is we just try to use as much as possible the knowledge that we have available and to decide about the dosing. And well, the worst error that you can make is just to prescribe the dose that you find in the textbook. So you really have to think about it. How is the renal function? Do I think that I need to give a higher loading dose in this patient with a high volume of distribution? And then you have to make an educated guess about how the clearance is, and you can verify it with determining blood levels. But on the other hand, when you get a blood level of yesterday, the patient can have changed, and there will be another situation. So it is almost a mission impossible to do it perfectly. But if you use all this information I just gave to you, use the information that is coming from the specific information that is given about the drugs, you can do better than just prescribing the dose of the drug that is the standard dose.
Well, Professor Gearbs, I really thank you for this great understanding of what's happening in the PK/PD features of drugs that we usually used or performed in our ICU patients. I'm sure that the information that you have provided us will make a clearer pathway for our ICU performance